So welcome guys, welcome to the INSS November 22 Cardiology recall session. So the first question, how was the paper? So I would give you two thumbs ups for the paper. I find it was an excellent paper and by far the best INSS paper in recent memory. The questions were of good standard. If you had prepared cardiology as a subject, you would be very happy. And I'm glad to say that a large chunk of the questions were from our videos, and that's reflected in the rankings also. So rank 1, 2, 3, 4, 5, 6, 7, all of this were our students. So again, you can even see the interviews on YouTube. They'll probably confirm this also on the interviews. So I want you to have realistic expectations when writing an INSS paper. So this is your rank list of those who got selected. So the first rank was 50 out of 80. So rank 1 got 50 out of 80. Okay. And what about rank 22? Rank 22 was the last person to qualify. He got 40 out of 80. And remember, there are 22 seats in the merit quota and 6 seats in the sponsored quota. So rank 22 just scored 50%. So even if you had only scored 50%, you would get a seat in an institute. So a very, very important thing for you to know. So there is no point in aiming for the heaven and earth. Okay. Even if you get 50%, if you just qualify, you would probably get a seat in an institute in cardiology. So I want you to have realistic expectations. It's not essential that you get 70%, 80%. You just need to get 50% to get a seat. And remember, rank 1 was only around 66%. Okay. So you can get a few questions wrong. You can leave a few questions. Okay. Do not put too much pressure on yourselves. The ranking suggests that you only need to get 66% for first rank and 50% to get a seat in an institute. So in this INSS paper, as usual, 50 questions from cardiology, 5 questions from biostats, 25 questions from medicine. And remember, we have recalled around 46 questions. Okay. So we were able to recall through our recall session and around 46 questions in cardiology. An interesting thing is the first 10 questions we recalled were the toughest questions. Okay. These were the questions which candidates found it easier to recall because they had pondered a lot on how to answer these questions. The questions you think a lot, you can recall them easily. Probably the 4 questions which we had missed were probably very easy questions which we find it very difficult to recall. Okay, so we come to question number 1. Which of the following is false regarding FFR versus IFR? So again, in all the questions, I've already marked the answers for ease. So IFR is more advantageous than FFR in predicting microvascular dysfunction. Normal value of FFR from aorta to distal vessel is more than 0.89. IFR is estimated in the diastolic period. FFR is superior in high output cardiac states. Now it's a pretty basic question. So again, we have already learned what FFR is. FFR is pressure in the distal vessel by pressure in the proximal vessel. So this proximal pressure is usually the aortic pressure. Okay. So PD by PA. So PD is pressure distal to the lesion. PA is pressure proximal to the lesion. If you have no lesion, PD and PA are equal and it is normal FFR is 1. If you have a lesion, PD drops and PD and FFR drops. When your FFR falls to less than 0.8, the lesion is considered to be significant and you can do an angioplasty or a bypass for this patient. So FFR of less than 0.8 is considered to be significant. It is distal by proximal pressures. So this is how you measure FFR. You give a vasodilator and your most commonly used vasodilator is adenosine. So remember, coronary artery flow is in diastole and it is usually phasic. So we give a vasodilator to make it non-phasic, so constant flow. So it makes it easier to measure FFR. In this case, you can see adenosine is given. Your PD is 68. Your PA, aortic pressure is 93. Diastolic pressures, the value is 0.73 and this is a significant lesion. Okay. Now the problem with giving adenosine is adenosine has a lot of side effects. Adenosine causes bronchospasm, can cause bradycardias, can cause atrial fibrillation. Besides, it's pretty expensive also. And in order to avoid that, we use IFR. So in IFR, you can see the phasic flow in diastole in a coronary artery. We select a period within diastole where the flow is relatively constant. So you can see this period here. Okay, this period here, the flow is relatively constant. We measure the PD by PA in this interval and this is called as IFR. Okay, we have all dealt with these videos. Okay, so this is the wave-free period. Okay, this is when we measure the PD by PA in a particular interval in diastole where the pressures are relatively constant, the flow is relatively constant. So these are two statements from Braunwald. Remember, in FFR, we use a vasodilator. If there is microvascular dysfunction, the distal vasculature does not respond properly to the vasodilator, hence IFR is superior. So microvascular dysfunction decreases the vasodilator effect of adenosine, hence FFR might be wrong. In this case, IFR is superior. Next statement is IFR overestimates the functional significance of a lesion when resting blood flow is abnormal, like in anemia. So when you have resting blood flow abnormality, we prefer FFR. So again, you need not know these 2 points because this is a pretty basic question. Okay, this is the wrong answer. IFR is more advantage than FFR in predicting microvascular dysfunction. This is true because microvascular dysfunction prevents the distal vasculature from reacting properly to adenosine. IFR is estimated in diastole. This is true. FFR is superior to high output cardiac states. This is also true. Remember, you need not know all the options to be true or false. You just need to know the answer. Okay. In this case, the answer is pretty simple. So you will see several questions in this recall session which were of decent standard and which were some questions were of such a high standard that I found it difficult to find answers for you. So in some of those cases I have given my opinions. In some of those I have also said that I could not find the answers also. So number 2, most common cause of heart failure in India, the answer is CAD. Okay, I don't know why people got it wrong because some people wrote it as rheumatic heart disease. The answer is clearly CAD. Now, if you have worked in your casualty, you will know that most of your cases of heart failure are something related to coronary artery disease. Okay, rheumatic heart disease right now is decreasing in India, and it is far less when compared to coronary artery disease. Okay, so this is the heart failure registry, the National Heart Failure Registry of India. Okay, which studied 10,851 heart failure patients, again all over India, village population, urban population, tertiary hospital, primary hospital, everything. So all over India was studied. Okay, and you can see here, ischemic heart disease is the most common cause of HFrEF, HFpEF, as well as heart failure with mid-range ejection fraction. You can see it's around 70%. So more than 70% of all heart failure cases are due to CAD. Rheumatic heart disease is 2.55%, so it's pretty much much lower quantity. Okay, so remember the data is from the National Heart Failure Registry, and even you can see the study came out in just 2 or 3 months prior to the exam. So this is the one which they expected. Okay, again, you need not think about it much. Remember, if you have worked in a casualty, most of the cases of heart failure you see are related to CAD. So in this relatively young cohort of patients with a mean age of 60. In Western countries, it's usually a far older age. Ischemic heart disease was the most predominant cause of heart failure. Hypertension and diabetes were your most frequent comorbidities. Answer is clearly CAD. Now, some people quoted this study, the Indus-Ukraine study, which said that RHD was the most common cause. Okay, this was a 2016 study. But again, this study usually studied village population. So although it studied village and urban population, more than 90% of your patients were from the villages and the average age was 39 years. So CAD is probably not yet developed in this subset of people. So again, it depends on what age you study. Okay, so this was a younger population, primarily a village population where rheumatic heart disease was probably rampant, and primarily a North Indian population. So again, there's no question. It is based on the National Heart Failure Registry. I don't think you can argue with the National Heart Failure Registry. Question number 3. Culture negative endocarditis with Staph aureus least likely associated with. I tried hard, but I cannot find the answer. So I have written alcoholism because I found a reference in one journal that alcoholism and culture negative staph is rare, but I cannot comment on this more. Okay, so for this, I can just say that I don't know the answer. Okay, again, the first 10 questions are pretty much tough because I told you we tend to recall tough questions faster. Question number 4. Chances of coronary ischemia is minimum with LCX from RCA, TGA correction, RCA from pulmonary artery, and intramural coronary arteries. Okay, the answer is LCX from RCA. Remember, what is the procedure of choice for TGA? It is arterial switch. Okay, it is arterial switch. Okay, what you do is you switch the arteries. So you cut the base of the aorta, cut the base of the pulmonary artery, and you switch them. Your coronary artery is taken and re-implanted. Okay, it is taken from the base of aorta and re-implanted in the base of the pulmonary artery. Okay, it is this which is the most common complication, the most feared complication. It is coronary obstruction or stenosis. This is what I have particularly mentioned in the TGA videos. Whenever a procedure is done to re-implant a coronary artery, whether it's an arterial switch or a Ross procedure, your most feared complication is coronary artery obstruction or stenosis. The other complications are supravalvular, PS or neo-aortic AS and neo-aortic regurgitation. So TGA is not the answer. RCFM pulmonary artery. What does pulmonary artery have? It has desaturated blood. So if the RC arises from the pulmonary artery, automatically it has to have desaturated blood. It is obligatory ischemic. So this is called as R kappa. Like Al kappa you have, this is called as R kappa. It's much more rarer. And intramural coronary arteries also we have taught. So this is my slides on ectopic coronary origins. Most are benign. Some are malignant, like AKOS with an intra-arterial course, anomalous origin of coronaries from opposite sinus. Intramural course, this is the option here. Slit coronary orifice, acute angle of takeoff, and Al kappa. So again, this is an AKOS. What you can see is with inter-arterial course. So you can see the LM is originating from the right sinus. So this is the right sinus, this is the left main, and it passes in between the aorta and pulmonary artery. You can see it passing in between the aorta and pulmonary artery. During exercise, the aorta and pulmonary artery enlarge, and this can compress the LM. So a very, very important point. So when you have an interarterial course, when the patient exercises, aorta and pulmonary artery enlarges, and this can have an interarterial course. So usually LM from right sinus and RCA from left sinus have commonly an interarterial course. So LM from right sinus and RCA from left sinus have commonly an interarterial course. Anomalous left circumflex from right sinus passes behind the aorta. It does not pass between the aorta and pulmonary artery. It passes behind the aorta. Okay. Again, it is difficult to expect you to know the course of all the anomalous coronary arteries. But again, even by using logic, TGA correction, we have told you the most common or the most feared complication is coronary stenosis. RCFM pulmonary artery or R kappa is obligatory ischemic. Intramural coronary artery, we have already taught you can cause episodic ischemia. The answer is LCX from RCA. So this is your intramural course. So you can see that normally the artery just pops out. So it straight away comes out of the sinus. Here what happens is it passes through the wall of the aorta for a certain distance and comes out. So when the aorta expands when you exercise, so when the aorta expands or when the stroke volume increases, this portion can get compressed. So this is called as intramural course. So we come to question number 5. 30-year-old patient with the following X-ray. Which of the following is most likely seen with the below X-ray? Again, difficulty in recalling the exact X-ray is a bit difficult, but some students said this was the X-ray. Okay, I'm not very sure about the diagnosis from this X-ray. Okay, so some said this is a annular constrictive pericarditis. Okay, so the constrictive pericarditis selectively involving the annulus or the mitral annulus. Okay, I thought this was a partially calcified mitral annuloplasty ring. Again, I find it difficult to relate with the above options. So for this question also, I am not very sure about the answer. Okay, so if you do come to know about this answer, please let us know. Question number 6. Which of the following is false regarding cardiac amyloidosis? Bone scintigraphy positive in ATTR amyloid, diffuse late granular enhancement in cardiac MRI, BNP low for the level of heart failure, and cardiac and nervous system involvement in wild type TTR. So again, basically amyloidosis is a tissue diagnosis. So what we do is, in a case of cardiac amyloidosis, so if the patient has cardiac amyloid, we can do a bone scintigraphy, generally with technetium. So we do a technetium bone scintigraphy. If it is strongly positive, you think of ATTR amyloidosis. If it is negative or weakly positive, you think of AL amyloid. So if a patient has cardiac amyloidosis, generally remember amyloid is a tissue diagnosis. But we can do a bone scintigraphy. If bone scintigraphy is strongly positive, we think of ATTR amyloidosis. If it is weakly positive, we think of AL amyloidosis. This is true statement. Diffuse LG enhancement in cardiac MRI, I told you again, remember amyloid fibrils rapidly take up gadolinium. Okay, and remember, amyloid fibrils are spread throughout the myocardium. So it is spread throughout the myocardium. Okay, it rapidly takes up all the gadolinium and you have a bright image. Okay, the term is difficulty in nulling the myocardium. Okay, so this is a true statement. BNP low for the level of heart failure. Okay, again this is true. I've told you what are the causes of low BNP in heart failure. The number one cause I've told you is obesity. Fat cells metabolize BNP. The more the fat cells you have, the less the BNP. 2. Acute heart failure, less than 1 hour. It takes time for the BNP to elevate. Number 3, CCP, chronic constrictive pericarditis and cardiac tamponade. Why? The atrium and ventricle are prevented from stretching. Remember, natriuretic peptides are released by stretch. When you have a fibrocalcific pericardium as in CCP or a fluid-filled pericardium as in tamponade, the ventricle and atrium cannot stretch. So these chemicals are released less. Number 4, I taught you was amyloid. So these were the 4 causes I taught you. Even in some case of diabetes, these were the 4 causes I told you of low BNP levels or less than expected. Cardiac and nervous system is involved in wild type. This is a false statement. Okay, this is my slide. Wild type, the only extra cardiac symptom is carpal tunnel. This I have told you repeatedly. The only extra cardiac symptom in wild type or senile systemic amyloidosis is carpal tunnel. It is mutant type which has cardiac and neurological involvement. Okay, along with carpal tunnel. So wild type, the only extra cardiac symptom is carpal tunnel. Mutant type or familial ATTR, it is cardiac as well as neurological. So this is your cardiac MRI. You can see here the entire muscle has lot of amyloid fibrils. The amyloid fibrils will take up all your gadolinium and the term is difficulty in nulling myocardium. Okay, and because it is a diffuse disease, your entire myocardium has amyloid fibrils. Wherever you take the biopsy, it is going to be positive. So endomyocardial biopsy is strongly positive. This is unlike sarcoidosis where you have patchy involvement. So because of the patchy involvement in sarcoidosis, you can have a negative biopsy. But here it is diffusely infiltrated. So you almost always have EMB positivity. Question number 7. Surgery related complete heart block is seen in all except TGA with intact IVS, calcific AS, TOF and subaortic VSD. Again, we have not taught you this directly, but we have taught you this indirectly. So this is my slide on aortic stenosis. I have told you why aortic stenosis patients can develop complete heart block. Okay, this is the aortic valve here. This is the AV node here. The aortic valve and the AV node are closely related. Okay, it is sometimes difficult to visualize. That's why this diagram helps. The aortic valve and the AV node are closely related. So if you have calcium in the aortic valve, this can extend into the conducting system and can cause heart blocks. That's why I told you AS can be associated with heart blocks. Now remember, if you place a prosthetic aortic valve here, this can also impinge on the conducting system which is nearby and can cause complete heart block. This is from VSD chapter. We have told you membranous VSD or perimembranous VSD, your conducting system passes near the VSD. So when you take a suture, when you take a bite to close the VSD, so we take a bite across and close the VSD, we can injure the conducting system and your most common defect is right bundle branch block and sometimes the complete heart block. So the VSD as such, the perimembranous VSD as such does not cause the complete blockage to the conducting system. It is when you take a bite to suture across the VSD that you develop the heart blocks and your most common is right bundle branch block. So keeping that in mind, calcific AS, yes, because the aortic valve and the conducting system are in intimate relationship. TOF and subaortic VSD, yes, remember perimembranous VSD is also called a membranous VSD, which is also called a subaortic VSD, so this is true. TOF, remember what VSD is present in TOF? It is a perimembranous VSD or a subaortic VSD. This is also true. The answer is TGA with intact IVS. Again, requires a bit of imagination. So question number 8, false about DiGeorge syndrome. Microdeletion of chromosome 22, yes, this is true. Conotruncal abnormalities, yes, this is true. We have taught you, it's associated with interrupted aortic arch, TOF, TGS, all those. Schizophrenia and Parkinsonism, again both of these are also true. Okay, so again all of these options are true. I'm not sure if the options were correct, if there's a problem with recall, but all of the options are correct. So DiGeorge syndrome or valofacial syndrome or catch-22 syndrome. We call this catch-22 after the famous novel. Okay, so it is a 22q11 microdeletion syndrome, and your cardiac abnormalities are usually a coronary abnormalities. You have abnormal facies, thymic aplasia, cleft palate, hypocalcemia or hypoparathyroidism. So again, your most common is TOF followed by interrupted aortic arch. And I told you in various journals you will find that IA or interrupted aortic arch is more common, but according to Park, it is TOF greater than interrupted aortic arch. I've even taught the same thing in your lectures also. This is from various reference articles. Schizophrenia and 22q deletion syndrome. Okay, 22q deletion is the most common genetic risk factor for the development of schizophrenia, and 1% of all your schizophrenic patients have 22q deletion. Schizophrenia with a low IQ, think 22q deletion syndrome. Okay, again, if you look at, there's an association between early onset Parkinsonism and 22q deletion also. That's why I said all 4 options are going to be correct. Question number 9. Which of the following needs dose reduction in combination with amiodarone? Now, the first 10 questions I told you are pretty difficult. It starts to get easier from now. So question number 9. Which of the following needs dose reduction in combination with amiodarone? Apixaban, digoxin, warfarin or metoprolol. Now, do we use amiodarone plus apixaban? Yes. Suppose we have, it's a non-valvular AF presenting in a fast ventricular rate. We can give amiodarone to correct to sinus rhythm, and you can give apixaban as an anticoagulant. Do we use amiodarone plus digoxin? Yes. Suppose a heart failure patient, suppose you have a HFrEF patient with a severe LV dysfunction who has atrial fibrillation. Okay, we can give amiodarone to restore to sinus rhythm and digoxin as an add-on drug for this patient. Do we use amiodarone plus warfarin? Again, yes. Okay. Suppose you have a valvular AF, mitral stenosis, rapid ventricular rate with atrial fibrillation. We can give amiodarone to correct to sinus rhythm, warfarin as an anticoagulant. Do we use amiodarone plus metoprolol? Yes. Suppose you have a post-MI patient. So a post-MI patient who develops a recurrent VT. For the VT, we can give amiodarone. For MI and prevention of VT, we can give metoprolol, beta blocker. So again, all 4 can be used in combination in clinical practice. Okay, but the answer is metoprolol. I'll tell you why. Okay, this is a statement from Braunwald. Amiodarone important interactions with other drugs occur are the dose of warfarin and digoxin and other antiarrhythmics should be reduced by 1/3 to half. So Braunwald gives you that when you give amiodarone, warfarin and digoxin should be reduced. Drugs with synergistic effect like beta blockers and CCBs should be given cautiously. So beta blockers can be given, dose reduction is not mentioned but should be given cautiously. Another thing is amiodarone is a potent inhibitor of cytochrome P450, A4A5 and P-glycoprotein. Again, this is a chart I taught you. Cytochrome P450, A4 and A5 metabolizes apixaban. P-glycoprotein metabolizes digoxin and dabigatran. CYP2D6 metabolizes your beta blockers. Okay, so another different system. CYP2D6 metabolizes beta blockers. That's why I said the answer for this is beta blocker. So apixaban, because amiodarone inhibits cytochrome P450, A4 and A5. Digoxin, amiodarone inhibits P-glycoprotein. Warfarin, again, it interacts with and increases the level of warfarin. So all of this is true. The answer is beta blocker because beta blocker is metabolized by CYP2D6. So question number 10, HIV drug causing hyperlipidemia. So I'm not sure whether this comes under medicine or cardiology. Okay, Maraviroc, atazanavir, stavudine and raltegravir. Okay, so remember HIV as well as heart both can cause dyslipidemia. The most common dyslipidemia in HIV is hypertriglyceridemia. When you give heart, you can have increased LDL, you can have first increased total cholesterol, increased LDL, increased triglycerides, decreased HDL. So this is roughly your lipid abnormalities when you give heart, some more than others, and protease inhibitors are your most common drugs causing lipid abnormalities. Okay, again this chart, this is a very important chart. I am not sure how they expect you to know. Maraviroc and raltegravir have the least effect on lipid metabolism. Okay, you can see stavudine here. Stavudine has a bad effect on lipid metabolism. I said protease inhibitors generally have the worst effect on lipids, but among the protease inhibitors, atazanavir has the least effect. Okay, so among the protease inhibitors, atazanavir has the least effect. So from this, you can see maraviroc and raltegravir, okay, they have the least effect on lipids. Although atazanavir is a protease inhibitor, among the protease inhibitors, it has the least effect. The answer is tavudine. Okay, I'm not sure how they expect you to remember this, but okay, there should be some tough questions. Okay, because remember, it is not only to know which balls you have to hit, you also have to know which balls to leave. Okay, so question number 10 is done. From now on, it usually gets easier. So question number 11, in which of the following is TAVR not ideal? Stroke 1 year back, 75-year-old with repeat surgery, 50-year-old with repeat surgery and aortic regurgitation, porcelain aorta. So stroke 1 year back, yes, you can do a TAVR. Remember, stroke is a complication of TAVR, but remember, we can do a TAVR in previous strokes. 75-year-old patient with repeated surgery, yes, this is an off-label indication. If you look in the slides which I've told you there are two off-label indications for doing TAVR. One is bicuspid aortic valve with severe AS. Okay, and two is valve-in-valve TAVR. Okay, so the so-called valve-in-valve TAVR. So suppose you have a mechanical aortic valve. Okay, this mechanical or a bioprosthetic aortic valve. Okay, or a bioprosthetic aortic valve. This bioprosthetic or mechanical valve develops prosthetic valve stenosis. You can implant a TAVR inside. So you can implant a TAVR valve inside a pre-existing valve. This is called as valve-in-valve TAVR. Okay, so this is an off-label indication. This is also true. Porcelain aorta. Porcelain aorta is something like this. You can see the entire aorta, ascending aorta, the part of the arch of aorta is entirely calcified. It has to come here. So this calcium is going to prevent the TAVR valve from coming here. But again, I have told you this. What can you do? You can do a transapical TAVR. So select an alternate route. You can call your surgeon. Surgeon will open up the apex and you can implant a valve through that. This is called a transapical TAVR. Again, this exact statement has been discussed in the videos. So again, one more thing is, why can't you do a TAVR for aortic regurgitation? Why can't you do a TAVR for a 50-year-old male? So why is TAVR trials done only in old? Why is TAVR done in old patients? Okay, one, TAVR trials were done on old patients. So TAVR trials were mostly done on old patients. And number two, TAVR was started around 2005. So you have data for TAVR valves only for 17 to 18 years. So you don't have data for TAVR valves beyond that. You have TAVR valves data only for 17 to 18 years. Whereas remember, you have a Starr-Edwards valve implanted in the 1960s, still functioning. So mechanical prosthetic valves, you have data for 60 years. Okay, so remember, this is a 50-year-old patient. He might live for the next 30 to 40 years. So again, you don't have data for the durability of those valves for that long. So remember, why is TAVR done in old patients? TAVR valves, TAVR trials were mostly done in old patients. And number two, you don't have data for TAVR valves beyond 17 to 18 years. Next is, why is TAVR not done for aortic regurgitation? Okay, we do it for aortic stenosis, not for aortic regurgitation. So let's say this is the LV here. Let's say this is the LV here. Okay, and this is the aorta here. Okay, so this is the LV and this is the aorta. Okay, so even in our videos we have repeated this. So remember, you need a bit of calcium for the valve to sit. Too much of calcium is bad, but for the prosthetic TAVR valve to sit, you need a bit of calcium. So aortic regurgitation, generally not much of calcium. The valve finds it difficult to stick. And what is AR? AR is a hyperdynamic condition. Okay, AR is a hyperdynamic condition. Okay, you have forceful blood being ejected out, and this can displace the TAVR valve. Okay, so two reasons why it's not done in AR. One, you need a bit of calcium for your valve to stick or sit. And two is AR is a hyperdynamic condition. The forceful ejection of blood can sometimes displace the valve. Okay. So stroke 1 year back, yes. 75 will repeat surgery. It's an off-label indication. Porcelain aorta, yes, you can do the transapical approach. The answer is 50-year-old with repeat surgery, because one, you don't do it in young patients, and two, you don't do it in AR patients. So which of the following is not a poor short-term prognostic marker for ACS? S3, yes, it is true. It is a poor short-term marker. Why? You have the CLIPS class. Remember, as you go from class 1 to class 4, mortality increases. So CLIP class 2, you can see S3 gallop. Okay. So again, it indicates bad prognosis. Remember, this is something I have taught you. 8% of the myocardium should be at risk to develop S4. 25% of myocardium should be at risk to develop S3. 30% of myocardium should be at risk to develop acute LVF. 40% of myocardium should be at risk to develop cardiogenic shock. This is something I have taught you in the videos. So again, S3 indicates larger amount of myocardium involved. Tachycardia, yes. Okay, tachycardia I have told you. When you have tachycardia, you think of impending LV failure. So a patient presenting with tachycardia, especially if it's an anterior wall MI, you think of impending LV failure. Two options. Okay, for these two options you have standard references. Options B and C, angina crescendo pattern in the last 48 hours and angina minimal exertion. Now, according to me, angina crescendo pattern in the last 48 hours is a poor short-term prognostic marker. Why? Because remember, this is indicating acute coronary syndrome. So again, increasing severity of angina, the so-called crescendo angina indicates a pre-infarction angina. Okay, so it indicates an impending coronary syndrome. So according to me, this is also a bad prognostic marker. I would say the answer is angina on minimal exertion. Okay, why? Because we refer several patients for bypass. So suppose you have a LM plus 3 vessel disease, we refer these patients for bypass. But often these patients do not do bypass. Say an 80-year-old female whom we refer for bypass, they sometimes do not do the bypass. They can develop angina on minimal exertion, but they never develop an ACS. Okay, for years together they pull on. So the moment they go to the toilet, they'll develop angina, but often they don't develop into an ACS. Okay, so that's why I write the answer as angina at minimal exertion. Okay. Okay, now we come to question number 13. Not a cause of cyanosis. A, unroofed coronary sinus. B, ASD pulmonary hypertension. C, VSD right left shunt. Again, a pretty simple question. VSD right left shunt, this is Eisenmenger syndrome. Again, it is cyanotic. Unroofed coronary sinus, again I have told you it is cyanotic. So you have a left SVC which connects to the coronary sinus. So what happens is, the coronary sinus is a venous structure which passes posteriorly, okay, to the LA and opens into the RA. So you can see it passing posteriorly through the LA, opening into the RA. There are holes in the posterior surface. Okay, and remember, this is associated with an LSVC. LSVC carries desaturated blood. This desaturated blood escapes through these holes, comes out into the LA, and this can cause cyanosis. So desaturated blood which is carried by the LSVC comes out through the holes in the coronary sinus and jumps into the LA, and this can cause cyanosis. ASD pulmonary hypertension, again remember, this is something I have taught you. Okay, this is the LA, this is the RA, this is the pulmonary artery. A hemodynamically significant ASD will cause an increased flow into the pulmonary artery. There is a left to right shunt, there is going to be increased flow in the pulmonary artery, and this can cause a hyperkinetic pH or a flow related pH. Okay, please refer the pulmonary hypertension modules. When you have a hemodynamically significant ASD, there is going to be left right shunt, more blood flow to the pulmonary artery, causing a hyperkinetic pulmonary hypertension. Okay, so the answer is ASD PHT. Now we come to question number 14. A 14-year-old patient on a ventilator with a BP of 90/60 on inotropes, heart rate of 140, ECG has been taken, shows the following changes. Which of the following is likely? Again, this is a straight repeat question. Okay, this is basically critical illness associated myopathy or critical illness associated ST elevation. Okay, this was the ECG it is given. Okay, again we have discussed this exact same ECG in our previous recalls. Okay, this is called as Pickel-Hopf sign or spiked helmet sign or Prussian helmet sign. Again, a straight repeat from our previous questions. Okay, how do you distinguish it from a STEMI? You look at the inter-RR interval, you can see a gentle slope upwards. So look at the inter-RR interval, you can see the gentle slope of the baseline upwards. So this is a classical STEMI, you can see an isoelectric baseline here. Okay. So you can see the isoelectric baseline in the inter-RR intervals. Okay. So the Pickelhaube or the Prussian helmet sign or the spiked helmet sign. Okay. Where you have diffuse ST elevation but with a particular pattern here. Okay. The spiked helmet pattern. So this mimics the spiked helmet. The clue is given by the inter-RR segment which has a slope upwards. So you have a gentle slope upwards. So any critically ill patient, the mechanism is adrenergically mediated prolongation of repolarization and a fusion of the preceding beats late and giant TU waves superimposed on the QRS complex. Okay. So again, this has all been discussed. Please have a look at that. So again, it's a recently described sign. So this is a June 2020 circulation article. So a recently described sign. So again, a straight repeat question, nothing much to explain. Question number 15. Severe asymptomatic AS with a normal EF, normal pulmonary artery systolic pressure, undergoes non-cardiac surgery. What is the next step? Add beta blocker, balloon valvotomy, TAVR, continue surgery with close monitoring. Straight away you can rule out two options. No role for beta blocker in aortic stenosis, no role for any medication in aortic stenosis. TAVR, remember you don't do TAVR in asymptomatic patients. TAVRs are done on symptomatic patients. Okay, now we have two options. Balloon valvulotomy and continuous surgery with close hemodynamic monitoring. Remember, I told you the indications for intervention in AS or replacement. What are the indications in asymptomatic patients? It is TMT. You do a TMT and TMT the patient becomes symptomatic or shows a fall in BP. Vmax of more than 5 meters per second. It is doing another cardiac surgery. And remember, this is a non-cardiac surgery. So if you are doing another surgery, for example, you are doing a bypass operation, CABG, and the patient has asymptomatic severe AS, you can replace the valve. And lastly, EF of less than 50%. It is doing another cardiac surgery, not a non-cardiac surgery. This is also the wrong answer. The answer is continuous surgery with close hemodynamic monitoring. Question number 16. Which of the following is an indication for intervention in an asymptomatic pregnant woman? Again, remember it is an asymptomatic pregnant woman. Severe MS with a TR of more than 4 meters per second. Again, this indicates severe pulmonary hypertension. Pulmonary stenosis of a gradient of more than 100. TS of gradient of 6. Severe AS with a gradient of 64. Again, I told you, we are not much bothered about right-sided lesions. Right-sided lesions are tolerated well in pregnancy. So this is not the answer. So severe MS with TR of more than 4 meters per second, severe AS of gradient of more than 64. Again, this created some confusion, but again the answer is pretty clear. For this patient, you give a beta blocker. Okay. For severe AS with a gradient of 64, you cannot give any medication. Remember, so this is the answer. So severe MS, TR of more than 4 meters per second, patient is asymptomatic. You straight away do not go for intervention. Remember, you give this patient beta blockers and try to stabilize this patient. Okay. Severe AS, there is no role for drugs. So you can do a balloon aortic valvotomy for this patient, stabilize this patient, conduct the delivery, and post delivery you can do an aortic valve replacement. Okay, it's a very straightforward answer. It created some degree of confusion, but it's pretty clear. For severe MS with pulmonary hypertension, you can give a beta blocker to stabilize this patient. Severe AS, you don't have any drugs. You have to open up that valve. You do a balloon aortic valvotomy, stabilize this patient, conduct the delivery, tide over the pregnancy, and then you replace the valve. So these are the conditions where pregnancy is contraindicated. Severe PAH of any etiology, universally bad. Remember, left-sided stenotic lesions, severe MS, and severe symptomatic AS. So severe MS irrespective of symptoms and severe symptomatic AS. DCM with an EF of less than 30, peripartum cardiomyopathy with residual LV dysfunction, and aortopathies. Pregnancy is high risk in, it is severe asymptomatic AS. So severe symptomatic AS contraindicated, severe asymptomatic AS, it is high risk. Okay. MS in pregnancy, mitral valvuloplasty can be performed in pregnancy but is reserved for refractory symptoms. Remember, it is refractory symptoms, not asymptomatic patient, or heart failure despite maximal medical therapy or hospitalization. What about AS in pregnancy? Valvuloplasty as a temporary maneuver for refractory symptoms, not asymptomatic people as in this case. So remember, just because you can give a beta blocker, the answer is not severe MS. Okay, even in symptomatic patients, the first step is always give a beta blocker. In fact, if you look at my pregnancy module, I have deliberately put in a case of severe MS in pregnancy and managed that patient with a beta blocker. So question number 17, 36-year-old with mild dyspnea on exertion with right upper limb pink, left upper limb blue. The probable diagnosis is truncus, type 1 AP window, PD Eisenmenger, TGA. So straight away two options are out, truncus and PD are out. Why? Uncorrected truncus and uncorrected TGA do not survive beyond infancy. Okay. What is the type 1 AP window? It is a communication between ascending aorta and pulmonary artery. Again, this does not create such a situation. For you to, the answer is obviously PD Eisenmenger, but it created some confusion for some students. For you to answer this question correctly, you need to know that the right upper limb is pink, the left upper limb is blue, both lower limbs should also be blue. Although this is not mentioned in the question, for you to answer this question, you need to imagine both lower limbs also to be blue. So how do we explain that? Let's say this is the aorta. Okay, so the first branch of aorta is the brachiocephalic artery. The second branch of aorta is the common carotid artery. The third branch of aorta is the left subclavian artery. Okay, first branch brachiocephalic, second branch common carotid, third branch is the left subclavian. Okay, the brachiocephalic artery gives rise to the right subclavian. Okay, so the brachiocephalic gives rise to the right subclavian. Okay, this is the pulmonary artery. Okay, for you to answer this question correctly, the PDA must be after the origin, before the origin of the left subclavian, but after the origin of the brachiocephalic. So for this question to be, for you to answer this question, the PDA should be after the origin of brachiocephalic, but before the origin of left subclavian. Now, if this patient goes in for Eisenmenger, what happens? Okay, if this patient goes in for Eisenmenger, your desaturated blood comes like this. Reversal of shunt occurs, the desaturated blood comes up the pulmonary artery and goes into the left subclavian as well as descending lower limbs. So what happens? The right upper limb is going to be pink. Okay, the right upper limb is pad. It is the PDA is after the brachiocephalic. So right upper limb is pink. Upper limb is pink. Okay, the left upper limb is going to be blue. Why? Because the left subclavian is after the PDA. Both lower limbs are also going to be blue. Again, all this confusion is not required. It has to be, differential cyanosis has to involve a PDA. Okay, and there should be a PDA Eisenmenger. So you can straight away mark PDA Eisenmenger, but this is just to explain to you the findings. So now we come to question number 18. Which of the following more likely seen with MS due to MAC than rheumatic MS except? So which of the following is more likely seen with MS due to mitral annular calcium than rheumatic MS except? So remember, we have taught you one thing. MAC causes MR much more common than MS, and usually it is a mild to moderate MR and usually a mild MS. So MAC causes MR much more common than MS. If MS occurs, it's usually a mild MS. Okay, so remember, MAC causes a mild MS. This is very important for you to know to explain this. So because MAC causes a mild MS, you have a low transmitral gradient. This is true. Because MAC causes a mild MS, you have a steeper early diastolic filling. Okay, remember, this is how we measure the mitral gradient in mitral stenosis. So this is the pressure half time. This slope is the pressure half time. In mild MS, it is something like this. In severe MS, it is something like this. The slope becomes more shallow in a severe MS. So mild MS, you have a steeper slope. So again, steeper early diastolic filling, this is expected in MS due to MAC. CT imaging is useful in assessing. This is true. Remember, in my slide, I taught you the Horus study. Okay, where they dug up Egyptian mummies and studied mitral annular calcium. So this was the study which I have showed you. Okay, the horror study. So if you had recall this, this would obviously be a straight answer. Okay, PHT cannot be used reliably. It underestimates the severity is false. It overestimates the severity. Okay, so pressure half time overestimates the severity of MS in mitral annular calcium. So that's the answer. So remember, low transmitral gradient is true. Why? Because it is a mild MS. Steeper diastolic filling is true. Why? Because it's a mild MS. CT, remember the horror study. Pressure half time cannot be used reliably in mitral annular calcium because it tends to overestimate severity, not underestimate severity. Again, you need not know this. You can just straight away rule out all the other things. So limitations of pressure half time: cannot be used in prosthetic mitral valves, cannot be used immediately post BMV, OMV and CME. You have to wait at least 48 hours. You cannot be used in increased left atrial pressure conditions like marked tachycardias. It cannot be used in increased LVEDP conditions like AR, AS, hypertension, and age-related diastolic dysfunction. Again, this is all purely echo. You can learn this when you become DM cardiology PGs. But again, for this, you can straight away, you can rule out all other options. So, question number 19. Which of the following doesn't require pacing in congenital heart block? Again, even if you don't know anything on congenital heart block, by looking at the options, you can straight away rule out. Associated long QT. Again, remember, this is bad. This causes a bradycardia associated Torsade de points. So bradycardia associated Torsade de points. Complex ventricular blocks, again, automatically require a pacemaker. More than 3-second pauses automatically require a pacemaker. No one is going to put in a pacemaker for a heart rate of 75. So again, you need not know much about congenital heart block. Straight away you can mark the answer. So congenital complete heart block. I've taught you two things. One, it is a suprahisian stable rhythm. And what are the causes? The first cause you think of is lupus. So neonatal lupus is your first cause. If you don't have lupus, then you think of other causes like congenitally corrected transposition of great arteries. You can think of left atrial isomerism. You can think of AV canal defects and certain types of single ventricle. So the first diagnosis is neonatal lupus. If there is no neonatal lupus, you think of CCTGA, left atrial isomerism, AV canal defect, and certain types of single ventricle. So again, this is your guidelines. If you are interested, you can read about it. So class 1 is if you have symptomatic bradycardia. Again, another class indication is if asymptomatic, then if the ventricular rate is less than 50 beats per minute, or if you have a wide QRS escape rhythm, complex ventricular ectopy, or ventricular dysfunction. These are your class 1 indications. Again, these are class 2A indications. You can pause the video and look at them. But again, you need not know much about this. Even if you have no idea on complete heart block, you are obviously not going to put in a pacemaker for a heart rate of 75. Which of the following is the most likely congenital abnormality? Again, a straight repeat question. Okay, this is scimitar syndrome. And this is due to PAPVC. Okay, again, nothing. This is the scimitar vein. You can see here. You can see dextro position of the heart. The dextro position of the heart of the scimitar vein. So what is the scimitar vein? The right lung, upper as well as lower pulmonary veins join together. This is the scimitar vein they form. Pierce the diaphragm and drain into the IVC. So the right upper lobe and lower lobe veins join together to form the scimitar vein. Okay, they pierce the diaphragm and drain into the IVC. This is part of PAPVC. Okay, there are lots of associated abnormalities. You have dextro position of the heart, you have lung atrophy on that side. So again, lots of abnormalities. Again, a standard exam question. Question number 21. Okay, they showed you tall T waves of hyperkalemia. Okay, the question was on tall T waves of hyperkalemia and asked the potassium level. So this was the potassium level 3, 4, 5, 6. Anybody with a first year knowledge of medicine should answer. It's obviously a potassium 6. So again, you have various standard tables. Okay, so potassium of such a level causes such an ECG change. So 5.5 to 6.5 hyper peak T waves, 6.5 to 7 you have P wave widening, PR prolongation and disappearance of P waves. 7 to 9 you can have bradyarrhythmia, sinus bradycardia, high grade AV blocks, bundle branch blocks, fascicular blocks. More than 9 you have sine wave, asystole, BF. Okay, again remember there is poor correlation. Okay, poor correlation between ECG changes and the potassium levels. Okay, let's say you have a CKD patient. okay, with a creatinine of say 7, he will tolerate higher levels of potassium very nicely. Let's say you have a normal patient who suddenly develops hyperkalemia. Let's say his potassium increases from 3 to something like 6. He will tolerate this potassium level very poorly and he can develop sine wave even at 6. So again, it depends from patient to patient. CKD patient, because of the acidosis, tolerate hyperkalemia well, whereas people with normal kidney function tolerate hyperkalemia poorly. So again, this is your standard textbook teaching, but remember, this does not have a direct correlation with it. I just want to say something else on ECG changes in hyperkalemia. Okay, this is your QRS complex. Okay, remember, hyperkalemia causes a abnormally fast repolarization and an abnormally slow depolarization. Okay, so anything beyond this is fast and this is slow. Okay, so what is going to happen is this part is going to compress. Okay, it's going to come like this. So what happens is you develop short QT interval. Okay, your T wave is going to compress, so you develop a tall T wave. So short QT interval, tall T wave. Okay, your ST segment, the length is going to decrease. The dimension of the ST segment is also going to decrease. Abnormally slow depolarization. Remember, QRS is going to widen. So QRS widens, PR is going to widen. Your PA is also going to widen and flatten. So again, just an interesting point. So hyperkalemia causes an abnormally fast repolarization. So your QT shortens, your ST shortens, your T wave also gets compressed, as a result your height increases. Abnormally slow depolarization. So again, QRS widens, PR widens, P wave becomes flattened. Okay, so just an interesting point for you to know. So question number 22, a very simple question. Which of the following is not a future complication of Kawasaki? Constrictive pericarditis, mitral regurgitation, future risk of MI, stress test likely to be positive. Remember, Kawasaki causes coronary vasculitis. This can cause coronary aneurysms and MI. Okay, something related to the coronary artery. Mitral regurgitation, yes, you can develop an ischemic MR. Future risk of MI, obvious. Stress test likely to be positive, again, yes. It has nothing to do with the pericardium. The answer is constrictive pericarditis. Okay, remember, it is a coronary vasculitis, has nothing to do with the pericardium. Question number 23. Patient with HOCM and hypotension, which of the following drugs can safely be used for the treatment of hypotension? Okay, the answer is phenylephrine. Here is a pretty logical thing. Okay, in HCM, inotropy is bad. Why? It increases the force of contraction, so increases obstruction. Tachycardia is bad. Okay, because it increases obstruction. Okay, norepinephrine causes increased inotropy as well as causes tachycardia. Okay, dobutamine increases inotropy, causes tachycardia. So this is, both of this is out. Levosimendan is an inodilator. Again, inotropy, increased force of contraction, bad. Phenylephrine increases systemic vascular resistance, causes vasoconstriction. Okay, it causes vasoconstriction, thereby decreases obstruction. Again, please look at the HCM module. I have told you the relationship between inotropy, between vasoconstriction, vasodilation, between giving various drugs and maneuvers. Again, this is just a derivative of that question. Remember, inotropy is bad in HCM, increases obstruction. Tachycardia is bad in HCM, increases obstruction. So norepinephrine, inotrop, dobutamine, inotrop, levosimendan, inodilator, all three are inotrops. They are bad. Phenylephrine does nothing to the inotropy. It causes vasoconstriction, increases SVR. Okay, thereby more blood is in the LV cavity, thereby decreased obstruction. The answer is phenylephrine. Question number 24. Which of the following statements is false? Okay, icosapentaenoic acid decreases TGL by 18%, LDL by 10%. Evinacumab is an ANGPTL3 inhibitor, decreases LDL by 40% in null variant of familial homozygous hypercholesteremia. Pempedoic acid is an A3B citrulose lyase inhibitor, decreases LDL by 15-20%. Inclisiran is siRNA decreases LDL by 50%. Again, all these three are true. This was a straight repeat question from the previous year's question paper. This option A was slightly changed. Okay, so options B, C, and D were asked in the previous question papers. These are true. Evinacumab is an ANG-PTL3 inhibitor which decreases LDL by around 40 to 50%. Pempidoic acid is an ATP citrate lyase inhibitor, it increases by 15-20%. Inclisiran is an siRNA, decreases LDL by 50%. All three are true. These have been covered. Remember, almost you have this anti-cholesterol drugs. Okay, almost all your drugs decrease LDL. Okay, so statins, evolocumab, cholestyramine, all those decrease LDL. Probably the only anti-cholesterol drug which increases LDL, it is omega-3 fatty acids. Omega-3 fatty acids are probably the only anti-cholesterol drug which increases LDL. Okay, so decreasing LDL by 10% is false. Okay, so this is the answer. Okay, so B, C, and D are straight repeats. Remember, all your cholesterol drugs, okay, they decrease LDL, and probably the only cholesterol drug which increases LDL is omega-3 fatty acids, and hence the answer. This is a false statement. Okay, a very simple question. They showed you a pressure tracing, okay, and LV-RV angiogram. They showed you the square root sign or the dip and plateau sign. Okay, they showed you the square root sign and asked you what is the condition. So CCP, chronic pulmonary embolism, EMF, PAH. The answer is straight away CCP. Okay. So what are the causes of square root sign? CCP, yes. Right. Restrictive cardiomyopathy, yes. It is acute RV failure. So this is chronic pulmonary embolism. Acute pulmonary embolism causes a square root sign, not chronic pulmonary embolism. So acute RV failure like RVMI, acute severe TR and pulmonary embolism. Acute LV failure like acute MR or acute AR can also cause. Okay. So why EMF? So this is obviously a wrong answer. Acute pulmonary embolism causes the square root sign. EMF is a restrictive cardiomyopathy. So why is this not the answer? Remember, in constrictive pericarditis, you can see both the RV and LV angiograms are bang on top of one another. The pressures are the same. In restrictive cardiomyopathy, you have a 3 to 5 millimeter, more than 3 to 5 millimeter pressure difference. So there's a more than 3 to 5 millimeter pressure difference in the LV and RV angiogram. So at this point, the waves are separated by more than 3 to 5 millimeters. So in the exam, they were bang on top of one another. That's why it's constrictive pericarditis. If there was a slight difference, so you have a square root sign like this, with a slight difference of more than 3 to 5 millimeter, then you can mark it as EMF, which is a form of restrictive cardiomyopathy. So which of the following statements is false regarding rheumatic fever? Again covered. Rising ASO is not diagnostic of rheumatic fever. I repeated this several times. ASO can rise in a lot of conditions. Steroid does not alter long-term prognosis in rheumatic fever. Yes. Remember that I've told you, rheumatic fever, the treatment is suppressive therapy. I've used the word exactly as suppressive therapy. This is the word I used in the first stage. It does not prevent development of rheumatic heart disease. It suppresses the symptoms. Chorea can be seen with absent inflammatory markers. Again, true. Again, chorea occurs late when ASO, CRP, everything is settled. Subcutaneous nodules indicates carditis. Yes. Subcutaneous nodules appear in crops when there is active carditis. Okay. So chorea, again, ASO, CRP, ASO, everything might be normal because it occurs late. Subcutaneous nodules, multiple crops indicate severe carditis, occurs in prolonged active carditis. And this was the treatment I told you. It is suppressive therapy. Steroids as well as aspirin suppress the symptoms. So treatment of rheumatic fever is only suppressive therapy, does not alter duration of illness nor prevent development of RHD. So question number 27, which of the following is wrong? Okay, 1/4 of ACS is due to plaque erosion. Plaque erosion is seen in plaque with thick fibrous cap. Mild stenosis compared to critical stenosis has more chances of causing MI. Majority of plaque disruption does not result in MI. Mild stenosis compared to critical stenosis will result in more number of infarction, not larger area of infarction. Again, there are 5 options. Okay, because some people actually had a difficulty in recall, so we have posted all the options. Okay, again, this is the answer is pretty clear. Okay, the answer is E. Okay, there are some points in this question even I did not know it. Okay, so again, this is something I've told you. This is from the exercise ECA chapter. Very important point I told you. Most heart attacks, 68% of MIs occur in lesions that were initially less than 50%. So 68% of all your MIs occur in non-significant lesions that were less than 50%. So 68% of MIs occur in lesions that were initially less than 50%, something like this. Okay. And the second point I wanted to know to answer this is preconditioning. Okay. So let's say this coronary artery gets occluded. Okay, this is a normally flowing coronary artery. This coronary artery suddenly gets occluded. You have a large area of infarct. Let's say this coronary artery, you have a pre-existing 95% lesion. This coronary artery gets occluded, you have a smaller area of infarct. Okay, why? Because this myocardium is preconditioned for ischemia. Okay, a normally flowing coronary artery, when it gets occluded, you have a larger area of infarction because of no preconditioning. This is a preconditioned myocardium. So you have a smaller area of infarct. Okay. So what is preconditioning? Brief periods of reversible ischemia prior to a prolonged occlusion reduces infarct size. Acute MI in previously normal or non-obstructive coronary arteries, large area of infarct. Acute MI preceded by angina, smaller area of infarct. So this was a normally flowing coronary artery getting occluded, no preconditioning, large infarct. Pre-existing lesion that gets occluded, smaller area of infarct. Okay. Also, I have taught you this, the underlying causes of culprit coronary artery lesions. I have said that plaque erosion is in 30 to 40% of cases. This is your plaque erosion. You can see fibrous cap is intact. Okay. So we'll now try to answer this question. 1/4 of all ACS is due to plaque erosion. So I've taught you it's 30 to 40%. Okay, it's a bit more similar. So we'll take this as true. Plaque erosion is seen in plaque with thick fibrous cap. Again, this is relatively a true statement. The fibrous cap is intact. It's usually a thick fibrous cap. Mild stenosis compared to critical stenosis has more chance of producing MI. This is true. Remember, 68% of all MIs occur in lesions that were initially less than 50%. We leave this here. This is also a true statement. I'll explain this. This is something I did not know. Mild stenosis compared to critical stenosis will result in more number of infarction, not larger area of infarction. So remember, majority of MIs occur in less than 50% of lesions. So this part is true. Mild stenosis causes more number of infarction. Yes, but not larger area of infarction. This is a false statement. Because no preconditioning is seen, it will cause a large area of infarction. So if you have a pre-existing mild stenosis, remember most MIs occur in lesions that were initially less than 50%. First part is true. But if you have a non-obstructive lesion going in for an MI, there is no preconditioning taking place, hence you have a larger area of infarction. So this is a false statement. So the answer is this. Okay, option number D is something I did not know. Majority of plaque disruption does not result in MI. So I just verified it in various articles. Okay, this was some coronary plaque disruption article which came out in circulation. So they say that plaque disruption itself is silent and the rapid growth is also silent. Autopsy shows that 9% of normal healthy people, so they died of some other cause, can have asymptomatic disrupted plaque, and 22% if the patient is diabetic and hypertensive. Many persons who die of IHD harbor both thrombosed as well as non-thrombosed disrupted plaque in their coronary arteries. There are a lot of studies done, but the basic sentence is this: the majority of plaque disruptions were asymptomatic. So this is something I did not know. Okay. Anyway, teaching you guys also teaches me a lot of things. Okay, so the answer is mild stenosis compared to critical stenosis will result in more number of infarctions. This is a true statement. Not a large area of infarction, it's a false statement. There is no ischemic preconditioning, you get a large infarct. Okay, which of the following is high risk in pregnancy? Pretty simple. Marfans with an aortic diameter of more than 4.5, this is a true statement. Large VSD, we are not bothered. TOF, corrected, uncorrected, partially corrected, we are not bothered. Right side obstructive lesions, we are not bothered. The answer is Marfan syndrome with an aortic diameter of more than 4.5. Okay, remember, if you have an aortopathy, okay, you want to avoid two things. As a general rule, if you have aortic dissection, you have aortic aneurysms, we want to avoid increase in aortic stress. We want to prevent stress on the aortic wall. And what causes stress on the aortic wall? It is tachycardia, vasodilation, and increase in inotropy or increase in stroke volume. So tachycardia, vasodilation, and increase in stroke volume causes an increase in aortic stress. All three occur in pregnancy. So you have tachycardia in pregnancy, you have vasodilation occurring in pregnancy, and you have increase in stroke volume occurring in pregnancy. So this is something which pregnancy poorly tolerates. Okay, that is why in most cases we straight away go for an LSCS, an aortopathy, so that we can control the BP, we can control the heart rate. So we can give a GA for the patient, control the BP, control the heart rate, rather than leaving the patient to undergo a vaginal delivery. So in the vaginal delivery, she experiences pain, she starts screaming, her BP shoots up, her heart rate shoots up. So you want to avoid all those things. So again, we have discussed when pregnancy is contraindicated, aortopathy. And what are the aortopathies where it is contraindicated? We have already discussed this. Bicuspid aortic valve with an aortic root of 50 millimeters, Marfan's 45 millimeters, Turner's 2.7 per centimeter squared, low STs with any aortic dilation, vascular Ehlers-Danlos, chronic aortic dissection. We have discussed all this in our slides. So pregnancy is high risk also we have discussed. So which of the following statement is wrong in a pre-op patient? Okay, this is something I have not taught you, but again it requires you to know something about the POISE trials. Okay, so remember high risk patients, so previous MI stroke patients, let's say they are undergoing a surgery. There were a lot of drugs which were tried before surgery to reduce the risk which they occur during surgery. So let's say you give a statin, beta blocker or aspirin, okay, pre-op to decrease risk of cardiovascular events. So you have a high risk patient, you give a drug like statins, beta blockers or aspirin pre-operatively to try to reduce their cardiovascular risk. So you want to prevent them from having an MI or a stroke. So this is the basis of the POISE trials. So POISE 1 studied beta blockers. Okay, in this patient, in this study, metoprolol 100 milligrams was given 2 to 4 hours prior to surgery and 6 hours post surgery. So on the day of surgery, 200 milligrams of metoprolol were given. 100 milligrams just before surgery, 100 milligrams just after surgery. Okay, it reduced the cardiovascular events but increased mortality and stroke. Okay, patient went in for hypotension. That is the main problem. Remember, these were patients who were never exposed to beta blockers. So you are giving 200 milligrams of beta blockers. Remember, how do we start beta blockers? We give 25 milligrams BD, 50 milligrams BD, TDS, and then go to 100 BD. So for beta blocker naive patients, straight away 200 milligrams of beta blockers were given within 10 hours. Okay, so these patients reduce cardiovascular events. MI decreased, but hypotension, stroke and mortality increased. Okay, so the general consensus was, do not start beta blockers within 24 hours of surgery. So do not start beta blockers within 24 hours of surgery. You can start a beta blocker before 24 hours to reduce CV risk. So do not start a beta blockers within 24 hours, just before 24 hours of surgery. If you want to start a beta blocker to reduce risk, you must do so before 24 hours of surgery and continue beta blocker therapy if patient already on beta blockers. So 3 very important points you should know from the POISE trial. Okay, one is if a patient is already taking beta blockers, continue beta blockers. If you want to start a beta blocker, do so 24 hours before surgery. Okay. Number 3 is do not start a beta blocker within 24 hours of surgery. So this was the recommendations of the POISE trial. The POISE 2 trial studied aspirin and clonidine. So 2 molecules were studied to reduce CV risk. One was aspirin and one was clonidine in patients undergoing non-cardiac surgery. The evidence was no benefit with either aspirin or clonidine. Aspirin increased the bleeds, clonidine increased the hypotension and bradycardia. So those were its side effects. Aspirin causes bleeds, clonidine causes bradycardia and hypotension. Okay, there was some benefit with aspirin in patients with prior stenting, But obviously the POISE-2 trial data was aspirin and clonidine actually showed a worse outcome. So aspirin increased the risk of bleeds, clonidine increased bradycardia and hypotension. There's something called the POISE-3 which studied tranexamic acid to reduce bleeds. You can have a look at it. Okay, and what about statin therapy? Small trials, it depends on the pleiotropic effect of statin. Okay, it decreased 30-day mortality, CV events, and even respiratory complications, infectious complications, and venous thromboembolism. This was due to the pleiotropic effect of statins. Okay, statin has multiple effects. So it decreased 30-day mortality, CV events, respiratory complications, infectious complications, and venous thromboembolism. So keeping that in mind, we'll try to answer this question. Aspirin in the pre-op improves ischemia risk. Is it true or false? It is false as per the POISE-2 trial. Okay, aspirin increases bleeds, clonidine increases bradycardia and hypotension. Beta blocker increases mortality in pre-op patients. Again, this is a true statement as per the POISE trial. If you have to start a beta blocker, start 24 hours before surgery. Do not start within 24 hours of surgery. So within 24 hours of surgery, do not start. If you have to start 24 hours before the surgery. Pre-op MI occurs within 12 hours. This is true statement. Remember I taught you pre-op MI is classically seen between 24 to 48 hours. Usually occurs within 48 hours of the surgery. 12 hours is fine. Pre-op stress test is indicated in high risk surgery. Again, this is true. Okay, we generally do not do treadmills in patients who are undergoing surgery, but in high risk patients, if you look in Braunwald at step 7, you have a pre-op treadmill. Statin decreases pre-op mortality. Again, this is a true statement. So for this, you need to know the POISE group. So question number 30, which TGL triglyceride is secreted from the liver and has partial dietary lipid? Again, it's a pretty straightforward question. It is VLDL. So again, you can see VLDL is secreted by the liver. Okay. Chylomicrons are produced in the intestine. They go to the liver. Okay. The LDL is again goes from the bloodstream to the liver. Okay. So again, the answer is straight away VLDL. You just need to know this chart. So VLDL is taken up, is secreted from the liver and contains triglycerides. Another simple question. Okay, nothing to explain in this question. Diabetic elderly man with a BP of 164/86. Okay, heart rate of 87. Choice of first line drug. Again, obviously, both of this is wrong because in almost all patients, you start a combination of drugs. At least two drug combination is chosen. So a single drug is not used. Again, beta blockers are not part of the hypertension guidelines now. So this is obviously wrong. Okay, so it's option D or E. Both are the same. So chlorthalidone is a diuretic. Lisinopril is an ACE inhibitor. Perindopril is an ACE inhibitor. Indapamide is a diuretic. So both of these are right. So depending on which answer was that was the answer. So remember, don't start a single agent. So obviously A and B are wrong. You need two agents. Beta blocker is not used as first line drugs now unless you have a compelling indication. So option C is wrong. The answer is option D. So you can either follow the ESC 2018 guidelines or the ISH 2020 guidelines. They keep on changing the guidelines. Sometimes fundamental changes occur. Okay. So it's according to the ESC 2018, it's A plus C or A plus D as your first line drug. Okay. According to ISH, it is A plus C as your first line drug. If it is not controlled, it is A plus C plus D. Okay. You can choose whichever guideline you want. Okay. Question number 32, another simple question. Which of the following risk factor for ventricular rupture except female, second MI, hypertension, reperfusion, or thrombolysis? Repeat question, it is second MI. This is my slide. Free wall rupture, fibrinolytic therapy increases risk. Elderly, hypertensive, female. Most common site, anterior wall. Junction of infarcted and non-infarcted myocardium. Most common artery involved, occlusion of poorly collateralized LAD. It is first MI and single vessel disease. All of this have been asked and this is a pretty straightforward question. So it is, remember, I've told you one thing, scar tissue protects against free wall rupture. Free wall rupture occurs when there is infarct expansion. Okay, scar tissue does not expand. So scar tissue protects against free wall ruptures. So again, this is a free wall rupture. You can see the rupture occurring here. This is a pigtail in the LV. You can see the free wall rupture occurring here. Free wall rupture, the treatment is surgery. Again, very difficult to salvage these patients. So you can see the free wall rupture here. So with each contraction, blood is going to leak into the pericardium and cause tamponade. Okay, another simple question. Okay, all the following are true for acute decompensated heart failure except sequential diuretic used for better response, again true. Okay, we add a thiazide diuretic along with usually metalazone along with loop diuretic like furosemide. This is called as sequential nephron blockade. Acetosalamide may be useful, true, especially in the patients in metabolic alkalosis. Okay, dose of IV diuretics is 2 to 2.5 times than the oral dose. Yes, this is true. This is as per the dose trial. Okay, SGLT2 inhibitors are used in every patient with ADHF. This is false. Remember, when I taught you HFrEF, I've taught you something. I've taught you the 4 pillars of HFrEF management. One is ARNI, ACE and ARB. One is SGLT2 inhibitors. One is beta blockers, and one is MRA. The 4 pillars of HFrEF management. This is for chronic heart failure. Okay, for acute heart failure, you give diuretics, you give inotropes, okay, you can give NIV, and you have a host of newer agents. Okay, SGLT2 inhibitors are used for chronic heart failure or once the heart failure is stabilized. Okay, loop diuretics, remember we consider furosemide or torsemide to be the drug for treatment of acute decompensated heart failure. So when the patient comes in pulmonary edema with all your Krebs and V's, we consider that to be the gold standard, but it is not being tested in a rigorously controlled trial. So it is mainly a practice-based guideline. It has not been tested in rigorously controlled trials. Okay. Again, this is a statement from Braunwald. Based on the results of the dose study, initial IV dose of 2.5 times the OP dose may be given in patients with chronic oral diuretic therapy, renal dysfunction, or severe volume overload. So let's say the patient is on furosemide, 40 milligram 110. And this patient comes in pulmonary edema, you can give the patient 100 milligram of furosemide. Again, this is something I don't agree. I find it ridiculous. Okay, I've even taught you that the drug of choice in pulmonary edema is nitroglycerin. Okay, but again, this is the dose study. Okay, this is a dose study. Okay, which came out in 2011. Okay, it studied 2 things. It studied bolus infusion of diuretic versus continuous infusion of diuretic. So bolus, you're giving Lasix 40 milligrams, 40 milligrams, 40 milligrams TDS. So let's say you're giving Lasix 40 milligram 111 versus Lasix, let's say 4 milligram per hour infusion. Okay, so Lasix bolus dose versus Lasix infusion dose, or a low dose strategy versus high dose strategy. So let's say the patient is on Lasix 40 milligrams orally, OPD. He's coming to your OPD and his oral dosage of tablet is 40 milligrams BD. Okay, low doses is high doses. When the patient comes in pulmonary edema, you give IV Lasix 40 milligrams, or the high dose strategies, you give IV Lasix 2 to 2.5 times the oral dose of 100 milligrams. So this was the dose study. It studied bolus dose of diuretic versus continuous infusion of diuretic, and low dose, that is the same OP dose. So if the patient is on Lasix 40 milligram, you give IV Lasix 40 milligram versus high dose, that is 2 to 2.5 times the oral dose. So if the patient is on 40 milligrams, you give 100 milligrams IV, and they found no difference in events. So whether you give bolus or continuous infusion does not make a difference. Whether you give a low dose strategy versus a high dose strategy does not make a difference. No significant differences were found in global assessment of symptoms or change in creatinine from baseline to 72 hours when diuretic was administered by bolus versus confusion versus continuous, or low dose versus high dose. Okay, that is why I say that you just don't keep on giving escalating dose of diuretics. When the patient comes in pulmonary edema, it's some sort of competition. So it's 100, 100, 100. Some people I've seen people giving 360 milligrams of furosemide in 24 hours and the patient becoming anuric. Okay, so you have the dose study, continuous versus bolus dose, both are same. Low dose versus high dose, both are same. Just keep that in mind. So again, that's why I said dose of IV diuretics used is 2 to 2.5 times the oral dose. That is true as per the dose trial. So again, you just need to know SGLT2 inhibitors are not used in acute heart failure. They are used once the heart failure is stabilized. Now let me confuse you a bit. This is a trial which has come out. This is called the Impulse trial. Okay, some people have actually told me that C was the answer, but this is wrong. This is the Impulse trial where empagliflozin was used in acute heart failure. So please read the trial. Empagliflozin was started 3 days after admission. It was not started on day one. Okay. So some people who sent me this trial saying that this was the answer, but Empulse trial, empagliflozin was started 3 days after admission, not on the day one. Okay. Again, a repeat question. Patient on treatment for depression, ECG given. What is the false statement? Okay. This was the ECG. Okay. This is sodium, again repeated twice in the recent years. Channel blocker toxicity. Okay. Typically, tricyclic antidepressants like amitriptyline, anticonvulsants. Remember, most of your anticonvulsants are sodium channel blockers. Local anesthetics are sodium channel blockers, but typically seen amitriptyline poisoning. I've told you, you have broadening of the QRS complex, you have prominent R waves in AVR, and you give charcoal, you alkalize it by giving soda bicarbonate. Okay, this is a straight repeat question. This is not a benzodiazepine poisoning. This is a sodium channel blocker poisoning. QRS increased risk of seizures. Remember, it is a broadening of the QRS complex. Terminal R wave widening in more than 3 and RS in AVR. Again, this is a true statement. Gastric decontamination with charcoal, true statement. Nothing much to explain. This is a straight repeat question. Remember, you have to do your repeats. It does no excuse. You at least you get 10 to 15% of repeat questions. Repeat questions are going to be scored by everybody. Okay. So unless you have to be thorough with your repeat questions. So question number 35, ECG pattern of posterior idiopathic left ventricular VT. Again, we have discussed this. It is RBB plus left axis deviation. We have discussed all this in the ventricular arrhythmia module. ILVT is also called as Bell-Hassan's tachycardia. Left posterior fascicular VT, RBB plus LAD. Again, my slide, most common. Again, anterior fascicular VT, RBB with right axis deviation. We have also taught this. Okay, posterior fascicular VT is RBB with left axis deviation. Anterior fascicular VT is RBB with right axis deviation. RVOT VT, this is an innocent VT. Okay, this is LBB with inferior axis. ARVD, it's a more malignant VT, can cause death. It is LBB with superior axis. So LBB morphology, I use the term morphology because left bundle branch block and right bundle branch block should be committed when the rhythm is originating from the atria, supraventricular rhythm. So this is a morphology. LBV morphology with inferior axis, RVOT VT, innocent VT. LBB morphology with superior axis, ARVD, can cause death. LVOT VT is RBB morphology with inferior axis. Again, please look at the ventricular arrhythmia module. All of this has been discussed. All are true about precapillary PAH except, again, this has also been discussed. I've taught you pulmonary hypertension as per the Ohm's law. Mean pulmonary artery pressure is equal to cardiac output into PVR plus LA pressure. Again, how is this formula derived? Please look at the video. It's based on the Ohm's law. Type 1, type 3 and type 4 are hemodynamically significant. Okay, where you have a mean pulmonary artery pressure of more than 20 millimeters, you have a PVR of more than 3 Wood units and LA pressure of less than 15 millimeters. So type 1, 3 and 4 are hemodynamically significant where you have a mean pulmonary artery pressure of more than 20, PVR of more than 3 Wood units and an LAP of less than 15 millimeters of mercury. Okay. So the answer straight away is resistance of less than 3 Wood units. MPAP if more than 20 is true. PAWP or PCWP less than 15 true. Hereditary mutation seen in BMPR is also true. Remember, bad prognosis. If you have type 1 PH due to mutation in BMPR2, bone morphogenetic protein receptor 2, it is bad prognosis. Answer is clearly resistance of less than 3 Wood units. Please look at the modules. Another simple question. Patient with EDV of more than 180. So what is this? LV is enlarged. Your normal end-diastolic volume is something like 100 to 120 ml. EDV of more than 180 or LV is enlarged. Okay, ESV of 60 ml and LAP of 15. So LA pressure is increased. What is the diagnosis? So again, acute MR, obviously wrong. LV is enlarged. In acute MR, the LV does not have time to enlarge. Okay, is it compensated MR? Okay, what is when do you look for when do you say it is decompensated MR? Okay, when the patient has symptoms of heart failure like dyspnea. Okay, when the LV EF is less than 60%, and LV end systolic volume is more than 40 or 45. Okay, the one guideline says it's 40, the another guideline says it's 45 millimeters. We just repeat this question. So now we come to another simple question. Question number 37. Patient has EDV of 180, ESV of 60, LAP of 15 millimeters. What is the diagnosis? So EDV of 180. What does this mean? LV is enlarged. Okay. So LV is enlarged. EDV is normally around 120 ml. Okay. What is the EF? EF is EDV minus ESV by EDV. So it is 180 minus 60 by 180. So it is approximately 120 by 180 or 66%. What is LAP? Normal LAP is 4 to 12 mm. So LAP is increased. So let's keep this in the back of the mind. Is it acute MR? No. Why? Because the LV is enlarged. Is it compensated MR? No. Why? Because the LA pressure has increased. Remember, in compensated MR, when do you suspect decompensation MR? One, when the patient is symptomatic, when dyspnea occurs as a symptom. Number two, when your LV EF is less than 60% or your LV end systolic volume is more than 40 or 45 millimeters. So the American guidelines and the European guidelines are slightly different. One says 40 millimeters, one says 45 millimeters. Irrespective of which, you can see the LV end systolic volume is much more, your LA pressure is much more. So it's not a compensated MR, it is decompensated MR. I don't know, I'm not sure why they put a diagnosis of MR with MS. It is obviously decompensated MR. Okay. So remember, acute MR, why is it not acute MR? Your LV has enlarged. Why is it not compensated MR? Because your end systolic volume has increased and your LA pressure has also increased. Okay. So it is obviously decompensated MR. Okay, question number 38. Which of the following is least likely associated with a diastolic murmur? So which of the following is least likely associated with a diastolic murmur? PDA Eisenmenger, yes. Why do you get a diastolic murmur? It is PR. It's a Graham-Steele murmur of pulmonary regurgitation. So it's an early diastolic murmur of PR, which is also called a Graham-Steele's murmur. ASD 3:1 shunt, you get a tricuspid diastolic murmur. So increased blood flow across the tricuspid valve produces a tricuspid diastolic murmur, which is a flow murmur due to increased blood flow across the tricuspid valve. Epstein's anomaly, also you get a diastolic murmur. Why? It is a diastolic MDM of TS. But remember, in Epstein's, TR is much more common than TS. Okay, TS is rare in Epstein's. It has been described, but TS is rare in Epstein's, and TS can produce a mid-diastolic murmur. TOF with absent pulmonary valve. Okay, this produces a sawing wood murmur. We have described this. It is a PS plus free PR murmur. Okay, you have ejection systolic murmur of pulmonary stenosis, and you have a murmur. You have a early diastolic murmur of PR or pulmonary regurgitation. Remember, there is no valve, so it is basically torrential free pulmonary regurgitation. The answer is Epstein's because TS is very rare in Epstein's. It has been described, but TS is rare. So PDA Eisenmenger, you get a Graham-Steele's murmur. ASD 3:1 shunt, you get a tricuspid diastolic murmur due to increased flow across the tricuspid valve. TOF with absent pulmonary valve, you get a PS plus PR murmur. Epstein's, although you get it, it is rare because TS is very rare. TR is much more common. Question number 39. Which of the following is true about anticoagulation for pregnancy with mechanical heart valve except? Anti-10A levels kept at 1 to 1.2 for effective anticoagulation. LMWH is true. This is true. Best maternal outcome is with warfarin. Again, this is true. Remember, I have told you, warfarin is distinctly superior to LMWH or UFH. Although we give LMWH and UFH, I have told you, warfarin is distinctly superior. You can still have prosthetic valve thrombosis when you give low molecular weight heparin or UFH. Okay, warfarin dose less than 4 milligrams, then no need to stop warfarin. This is also a true statement. Best fetal outcome with UFH, this is the false statement. Okay, a very simple question. This is a table from Braunwald. You can see here anticoagulation related fetal and neonatal events. You can see LMWH no reported adverse events for the fetus if you give low molecular weight heparin. UFH has a 7.6% or a 7.6 confidence interval of having adverse events. And what are the adverse events? It was actually intraventricular hemorrhage in premature infants. Okay, so intraventricular hemorrhage in premature events, around 4 patients were reported when you give UFH. Again, there's a controversy because prematurity itself is associated with intraventricular hemorrhage. So we are not sure whether it was heparin or the prematurity causing the IVH. But here with this table, this has been subtly changed in the new edition of Braunwald. You can see it is LMWH alone as the answer. So anti-10A levels you keep for 1 to 1.2 while giving LMWH. Warfarin is the best agent. It is much better than LMWH or UFH. And less than 5 milligrams you can give continue warfarin. The answer is UFH. Best fetal outcomes with UFH. Another simple question. Condition described in this X-ray is not associated with. They gave you a boot-shaped heart. So you can see the boot-shaped heart here. Okay. Answer is TOF. Okay. And they asked you it is not associated with. The answer is restrictive VSD. So I told you TOF or TOF physiology or is associated with RVOT obstruction plus non-restrictive VSD. Large non-restrictive VSD. This is what I told you. When you mean by TOF or TOF physiology, or when you say squatting spells, you mean RVOT obstruction with a non-restrictive VSD. It has been repeated several times. So obviously the answer is restrictive VSD. TOF is associated with PR, is also associated with bronchial abnormalities. It is clearly a restrictive VSD. Question number 41, we've not got the exact question. Okay, they gave you the ECG which showed D Winters T waves. Okay, you can see the D Winters T waves here. So primary VCA associated with, done within 12 hours. Yes, this is true. Maybe associated with ST elevation lead AVIA. This is also true. Again, remember it's a proximal lady occlusion. Okay. Obviously, option C and D we cannot recall. So one of them must be wrong. We have discussed extensively on the D Winters T waves. D Winters part of a STEMI equivalent. So you can see the STEMI equivalents we have discussed in the videos. Okay, this is the D Winters T wave. You have an upsloping ST depression. Okay, with a rocket-like T wave. So you have an upsloping ST depression transferred to a rocket-like arrowhead-like T waves. Question number 42. Which of the following is wrong about aortic regurgitation? LV EDP equalizes LA pressure in acute AR. This is a false statement. You can have a look at the videos. Remember, in every person, LV EDP is equal to LA pressure is equal to pulmonary capillary wedge pressure. This is true for every person. However, what happens in acute AR is you have a premature closure of mitral valve. So the mitral valve is forced close. So there is so much increased blood in the LV that the mitral valve is forced closed, or the mitral valve is closed in diastole itself. Okay, it causes a premature closure of mitral valve. Okay, and that is why in these patients LV EDP is more than LA pressure. So normally in every person LV EDP is equal to the LA pressure, which is equal to the pulmonary capillary wedge pressure. But in acute AR, there is so much blood in the LV that this mitral valve is closed shut by the increased blood. That is why you have a premature closure of mitral valve, and that is why LV EDP is more than the LA pressure. This is actually a protective mechanism because the LA pressure is prevented from rising, hence you have less chance of developing pulmonary edema. That is why acute AR presents to you in shock and pulmonary edema is rare. The very important point. In acute AR, you have a premature closure of mitral valve because the LV EDP is so high, it closes the mitral valve. Thereby, LV EDP is more than LA pressure. So that is a protective mechanism actually because the LA pressure does not rise to that levels. So pulmonary edema is rare. Patient mainly presents to you in shock. Atrial pacing is helpful. Remember in our videos we have discussed something. We have discussed that tachycardia and vasodilation is good in chronic severe MR. Okay. In fact, many people answer this question with the help of that. I've told you that marathon runners, okay, there are people who have chronic severe AR who have run marathons. Why? Because when you run, you have tachycardia. When you run, you have vasodilation. So there are people who have completed marathons okay, who have chronic severe AR. Okay, there are people who have completed marathons with a diagnosis of chronic severe AR because tachycardia and vasodilation decreases regurgitation, makes them feel much better. Okay, again a Doppler was shown. Okay, which of the following, this following Doppler was associated with pulsus alternans or pulsus bisferiens. Again, we are not sure what Doppler was shown. Okay, basically, if it is something like this, where the patient had severe AR, okay, then this was probably bisferiens. Okay, if there was severe AR, it was probably bisferiens. Okay, if it was something like this where the patient had severe AS, then it was probably pulsus parvus. Okay, so we are not exactly sure what the Doppler was shown. Most of the students said that it was severe AR which was shown, hence the diagnosis would be bisferiens. Okay, so if it is severe AR, it's likely bisferiens. It was severe AS, something like this, tongue shape gradient of more than 4 meters per second. It is most likely pulsus parvus. But the consensus of most students was it was severe AR, hence it was probably pulsus bisferiens. Which of the following agents do not cause hypertension? Okay, smoking, licorice, modafinil, abiraterone, and minoxidil. Okay, the answer is minoxidil because minoxidil is used in the treatment of refractory hypertension. So when you have resistant hypertension, sorry, it is used in the treatment of resistant hypertension. Okay, it is more commonly used nowadays as a hair growth agent. So people who have alopecia, by applying minoxidil drops, it causes hirsutism. So it causes hair growth. Okay, but remember it is a reserved drug for resistant hypertension. So obviously it does not cause hypertension. Okay, if minoxidil was not there in the option, my answer would be smoking. Okay. Licorice causes hypertension, modafinil causes hypertension, abiraterone is a steroid, okay, which is used in prostatic cancer, so it causes hypertension. So smoking is not consistently related with hypertension. Okay, smoking acutely increases BP. In the chronic, we don't have data. Smoking acutely increases the blood pressure, but in the chronic long run, we do not have much data for this. Okay, remains difficult to define because of confounding increases in waist girth caused by smoking cessation. So each cigarette evokes a transient pressure response. Okay, so vasopressive effect. Okay, so in the short term, you have data that it increases. In the acutely, it increases the blood pressure. Chronically, we don't have much data. So I think minoxidil was there in the answer, so probably that would have been the answer. If it is not there, in that case you can mark smoking because it has somewhat confounding effect. Okay, question number 45. Which of the following is false regarding pretest probability? It's a very simple question. Okay, pretest probability of CAD does not depend on characteristic of pain. Even if you don't know anything on exercise ECG, you can straight away answer this is false. So obviously anginal pain is different from non-anginal pain. So if a patient has anginal pain, he has a higher pretest probability. Males have a higher pretest probability. This is true. Pretest probability is age dependent. This is true. I'll come to option number D a bit later. This is my slide. Most important step is calculation of pretest probability. And this is the slide I gave you. Okay. So in this slide, I've told you that you look at age here, you look at gender here, and you look whether it is typical angina, atypical angina, or non-anginal or asymptomatic. So this is the slide I gave you for calculating pretest probability. Okay. One thing I did not teach you, actually I did not know, was this is also called the Diamond Forestier chart. Okay. I did not know this. This is also called the Diamond Forestier chart. Where else have you heard of Diamond Forestier? It is part of the hemodynamic classification of MI. So just like you have Philip class 1, class 2, class 3, class 4, you have Diamond Forestier 1, 2, 3, 4. Okay. But even if you did not know anything, obviously option A is the answer. A person having anginal pain is obviously different from non-anginal pain. Again, this chart has been taught, we in fact discussed. So if a female in the reproductive age group presents with atypical pain, extremely unlikely. Any person presenting with asymptomatic pain, extremely unlikely to have a high pretest probability. So we've discussed all this in the exercise ECG module. Please have a look. So last question. Noonan syndrome, all except leash nodules, autosomal dominant, bleeding diathesis, rasopathy. Leash nodule is part of von Recklinghausen's disease or neurofibromatosis. Okay, it is not part of Noonan syndrome. So this is Noonan syndrome we have discussed almost everything about Noonan syndrome. Okay, it is a rasopathy, PTPN11 gene, autosomal dominant. You have cardiac defects. The most common cardiac defect is pulmonary stenosis with a dysplastic pulmonary valve with left axis deviation. You can have ASD, HCM, VSD, and peripheral PS. Again, I've taught you this. Peripheral PS questionable. Okay, although Park gives you as this chart, but peripheral PS is questionable because this is a statement from Braunwald. Peripheral PS excludes Noonan syndrome. Again, I've told you this has been asked in your exams also. In fact, last INSS also was asked. So the associations of the Noonan syndrome, most common is pulmonary stenosis with a dysplastic pulmonary valve, ASD, HCM, VSD, and peripheral PS. Again, peripheral PS is questionable because Braunwald excludes it from the diagnosis from peripheral PS, cause of peripheral PS. Hematological disorders are seen in 30 to 72% of patients. Okay, it is due to dysfunction of platelets, thrombocytopenia, von Willebrand disease, and deficiency of clotting factors. So a lot of things, but again, almost all of you would know that Noonan syndrome has nothing to do with leash nodules. So neurofibromatosis. So with this, we come to the end of the presentation. So INSS number 22. For me as a teacher, I'm extremely happy with the results. Most of the students have said that a large number of questions have come from our video sessions, and that is also reflected in the rankings. Now, for people who did not get it, okay, remember that only 40 out of 8 is 50% was the criteria to qualify for an institute seat. Okay, so I think it is a very attainable criteria. Even if you are a pediatrician who finds it difficult to study medicine topic, if you put your heart in it, if you concentrate on cardiology and biostatistics, even with your basic medicine knowledge, you can still get a cardiology seat in the institute. So thank you guys, and hope you're doing well. Thank you.